Ladies and gentlemen, welcome to the afternoon session on system improvement for better outcomes among out-of-hospital cardiac arrest patients. I'm Lynette from the Lee Kuan Yew School of Medicine, and I'll be your MC for this afternoon. To kickstart this session, we have Professor Tan Hyang Kun, Group Director, International Collaborations, SingHealth, and Director, SingHealth, Duke NUS Global Health Institute, to deliver the opening speech. Prof. Tan, please.
Thank you. Hi. A very good afternoon, colleagues, partners, friends from the region, ladies and gentlemen. I'm absolutely delighted to see that we have more than 500 participants from Indonesia, Malaysia, Philippines, Thailand, Vietnam, Singapore, and other countries in Asia attending this hybrid event. This event is jointly organized by SingHealth International Collaboration Office and Unit for Pre-Hospital Emergency Care, or UPEC, with support from Temasek Foundation. We at SingHealth, Duke NUS, have the opportunity to develop and implement over 30 capacity building programs together with our partners in the region. This includes several emergency preparedness and disaster management initiatives. We are heartened to know that, to date, our programs have impacted many countries within ASEAN and beyond. And through our capacity building program, we have mutually learned and share best practices and many other aspects of healthcare, and has fostered partnership and relationship across many countries. In fact, the very fact that we are all here today is a testimony to the great friendship that we've built over the years. Now, although the pandemic has forced us to rely on virtual method to continue our programs, our efforts have never really ceased. But today, you can certainly see a change. This is the first event that's conducted over a hybrid platform since the start of the pandemic. I'm hopeful that we'll have more physical meeting in near future. Just commenting to Marcus that it is just different. When people see each other, the excitement is palpable. So I'm just absolutely delighted that we can have this today. And today is the first day of a 5-day hybrid program. We will continue another 2-day program sometime, hopefully in November 2022. Once we've completed the 5-day program or workshop, our teams of trainers will be visiting your countries to conclude the program. And selected participants will also be invited to Singapore for immersion training. We look forward to seeing you all in your respective country in the near future. Now, let me first thank my ICO team for helping to organize this, and certainly together with the colleagues from UPEC for all the hard work. And to all our partners, thank you for taking time here, and thank you for all the colleagues in the Zoom space for taking time on a Saturday morning to participate in this event. Last but not least, I wish all participants happy training and a great success to this SingHealth Temasek Foundation Pre-Hospital Emergency Care Program. Thank you.
Thank you, Prof. Tan. We will now invite Dr. Gayatri Nadarajan, Emergency Medicine Consultant at the Singapore General Hospital and a pre-hospital doctor from the Unit of Pre-Hospital Emergency Care, to speak to us on the Global Resuscitation Alliance 10 Steps to Improve Out-of-Hospital Cardiac Arrest in Asia. Dr. Gayatri, please.
Good afternoon to one and all, and thank you very much for giving me this opportunity to share with you stories from around Asia to actually depict the GRA 10 steps. So firstly, what's GRA? So GRA refers to the Global Resuscitation Alliance, which has the goal of improving OHCA outcomes by 50%. And we plan to do this by the Resuscitation Academy model, which actually focuses on identifying best practices and helping to facilitate its implementation through the train the trainers model. So this is a bit of a story about how the GRA came about. So initially it started off as the Resuscitation Academy in Seattle, which focused on training the paramedics and the EMS, various stakeholders in the EMS system to actually have the skills to improve their cardiac arrest outcomes. But then they found that there needed to be more advocacy and more uptake of these best practices. Hence, the Global Resuscitation Alliance evolved and came about to actually help to spread these good practices globally. Okay. So the GRA has identified 10 steps, and they've also published 3 books where in these books there are narratives of how the communities have adopted these best practices to improve the cardiac arrest survival. And an important element that they realize is that it's not just it's not just enough to actually publish papers and show the evidence. So to actually have the medical science implemented, you actually need an educational strategy, and you also need the local implementation to ensure that this medical science is actually implemented and actually translated into good survival. So if you look at this slide, so in this slide you have the 10 steps, and then you have the programs to actually help you implement these 10 steps into practice. Okay, and I believe throughout this day, in the whole session in the morning, many of these 10 steps were depicted in the stories that were shared by the speakers. Okay. However, we've realized that for many of the developing pre-hospital systems, achieving these 10 steps is a very big leap. So if you notice here, I've actually described it as developing pre-hospital systems rather than calling it developing countries or LMICs. Okay, this is because even in developed countries, and even within a country, there are various different pre-hospital or EMS systems. And each of these systems may be at different stages of development. So for example, even in Singapore, even though SCDF is our main pre-hospital system, we have various private ambulances who also bring patients to the hospital, and each of them are at different stages of development. Okay, so we found that for many of them, achieving these 10 steps is a huge leap, and there need to be baby steps or certain elements in place to actually help them achieve this. Okay, so this is how we actually came up with the frame of survival during our consensus meeting in 2017. And if you look at this, the focus is on the chain of survival, but there are 2 frames, the inner frame and the outer frame. And the inner frame talks about elements which are within the control of a pre-hospital system, which we can actually work on. The outer frame focuses on the bigger on elements that are a bit beyond the hospital and beyond the pre-hospital system, such as having government buy-in, legislation, and so on. Okay. So following the consensus meeting, we found that many of our neighboring countries found it a bit more easier to implement the GRA 10 steps. I'm just going to take you through some of the countries and their stories and how it actually impacted the OHCA survival. Okay, so firstly, we're looking at Bangkok, at this district, Bangkok Noi. Okay, so if you look at this picture, in this district, there's an issue with accessibility. So if an ambulance was to actually reach the patients in the villages, they would actually have to go through very narrow slums, and it's very hard to even bring a stretcher. And in some places, we actually have to get the boat to actually reach the patient itself. So thinking out of the box, what the pre-hospital team thought about was to actually train motorcycle taxi drivers in performing bystander CPR. Okay, so what they started was this hands-only CPR program, and together with that, they also actually certified them as community first responders. And they also had an app similar to our My Responder app to help identify patients when there is a cardiac arrest, so that actually the first responders can reach them even before the ambulance is able to reach them. Okay, so again, at the beginning, they actually had to get buy-in from the stakeholders, right? And this is one of our team members, Dr. Sata, the one in the blue shirt, right? And part of our team who is actually talking to the stakeholders and getting them involved. Okay, and once there was buy-in, they were training the motorcycle taxi drivers to actually be able to, understand what is a cardiac arrest and how to perform hands-on CPR and so on. Okay. So what they found that there was a significant increase in EMS utilization and bystander CPR. Interestingly, the part about EMS utilization is a very important finding because in many of these LMICs, there is still a lack of understanding that, okay, if there's an emergency, you should call an ambulance, because some of them feel that, okay, maybe it's faster to just take a taxi to the hospital or to just bring, my relative over to the hospital myself, without understanding that interventions can be done in the ambulance that can actually help improve outcomes. Right. So a similar model was actually used by the Thailand EMS system to actually train condominium officers in being able to perform bystander CPR and being first responders. Okay, and these are some pictures showing what they had implemented this year. Okay. And an important part was that it also, it's not just about training them, but it's also about auditing and making sure that, the training is effective. So they conduct simulation in situ to actually audit the system. Okay. Right, next we'll be moving on to Indonesia. Okay. Right, so we're looking at Malang. Okay, so in Malang City, they actually have conducted a CPR training for churchgoers. Okay, and similarly, they also have done that for the schools. Okay, and it's interesting to see that it's not just the key players involved in training are not just the paramedics or those involved in the pre-hospital system, but you also have the emergency and disaster nursing chapter who actually helped out with the training of the first responders. Okay, and they actually did, and they also did a survey as part of their training, and then they found that there were lots of gaps in the knowledge of CPR and AED, but at the same time, there was lots of willingness to learn. So another interesting finding was the higher scores with people with higher education background. There have been similar studies that actually show that people in lower socioeconomic groups are less likely to perform bystander CPR. And I guess this is something that we all can think about as we all aim for equitable health access for everyone to actually improve cardiac arrest outcomes. Okay. So here are some pictures, and I think the one wearing the red shirt is Dr. Ali Haider, which is sitting in front here. Okay. So some of the challenges that they have faced are things like money to support the programs, a low uptake by volunteers, and many of it's related to the time. So for example, the taxi drivers, they had issues with keeping up to their training program because time meant money for them, and therefore that was one of a challenge. Then with the phone application, there are IT issues such as using up the battery or updating the system itself. Then there's also issues with lack of public access AED, and also the community not understanding the importance of CPR. So there's some of these notions that, okay, if someone had a cardiac arrest in a temple or a church, it's just fated, and that's the way it should be, and we shouldn't intervene. So even getting buy-in from to actually train people in places of worship is a challenge itself. Okay, next moving on to Penang in Malaysia. Okay, so in Penang, they have a pretty comprehensive program to actually improve cardiac arrest outcomes. So the HeartSafe program has been there since 2015, which have seen AEDs in many public places and which are supported by NGOs. They also train schoolgoers in CPR, and they also have a Good SAM application similar to our My Responder app. And they have this community first responder team, which are volunteers trained in basic first aid and CPR, who would actually be patrolling the areas, and if there is any emergencies, they would respond first, even before the ambulance arrives. Okay, and here are some pictures from Penang itself. Okay, and this is another story, another success story, where a 49-year-old man was actually saved by school students performing CPR on him. Okay, and this is another success story where one of the lorry drivers lost consciousness and actually had met with an accident. A firefighter who was off duty saw this and actually realized that he had actually lost consciousness first. So he actually performed bystander CPR on him before the ambulance arrived, and he actually made it. Okay, right. And this is the team that actually helped him survive. So some may say, okay, the stars all align, and that's why he survived. But in order for the stars to be aligned, you need the elements to be in place first. And in this Penang system, they have the volunteer first responders, they have the firefighters and the paramedics to perform high performance CPR, and eventually reaching the hospital and having good advanced care. Okay, so I guess in the morning there were lots of talk about COVID and some of the challenges faced. And this is just a recap of the challenges that were faced during COVID, which is similar across Asia. But is there a silver lining? So interestingly, with COVID, I think it brought the community closer to the healthcare system, and it also created more awareness in the importance of an emergency system in responding to disasters and outbreaks such as COVID. So there's much publicity that came about with COVID that may actually work to our benefit now as we try to improve cardiac arrest outcomes. So for example, how Philippines were riding on the wave with COVID. So they employed, just like all of us, using IT to actually conduct training online and continuing the CPR training to improve their cardiac arrest. Okay, and in Philippines, they also found that there was a bit more of the dispatch system strengthened because there was more funding going into it to actually help deal with the COVID outbreak, and as a result of that, the dispatch system strengthened during COVID itself. Okay, so some pictures from Philippines itself. Okay, right. So moving on, okay, it's my last few slides. Okay, so it's not just about cardiac arrest. If we look at all these stories, in all of these countries and all of these systems were aiming to improve their cardiac arrest outcomes. But in actually aiming to do that, they ended up improving their pre-hospital system. And some of the common elements that we noticed was that there was good collaboration between the EMS, government officials, and the public. And also, we noticed that this whole collaboration and this whole effort to improve cardiac arrest outcomes made the public more aware about the EMS or the pre-hospital system and that how it can be used for emergencies. Through improving the out-of-hospital cardiac arrest, there has also been an improvement in the EMS systems by instilling within the pre-hospital system the practice of collecting data, of actually auditing, and of quality improvement, and also engagement of various stakeholders to actually improve outcomes. So it's not just about cardiac arrest, but it's about actually improving the whole EMS system to actually improve outcomes such as cardiac arrest, but this also applies to other time-sensitive conditions. So if we look at the chain of survival, out of the 5 rings, 4 of them actually involve the pre-hospital or the EMS systems. So when we actually aim to improve the pre-hospital systems, we are actually improving a big chunk of the health system itself. Okay, and this can also apply to other time-sensitive conditions. So if you're talking about the early recognition of stroke, or even the early recognition of ST elevation MI, heart attacks, or even in pregnancy, the recognition of postpartum hemorrhage, which is heavy bleeding during pregnancy. And even with the communicable diseases, if we're talking about things like gastroenteritis or pneumonia, which many people do die of, it's about the early intervention and the early treatment that will actually make a difference to the outcome and give good quality outcomes. Okay, and this is important because if we look at the top 10 causes of death worldwide, okay, we've moved away from actually having communicable diseases as the issue, and now we are actually moving towards the non-communicable diseases. And for all of this to have good outcomes, it's important to actually improve the health systems, which include the pre-hospital system. So it takes a system to save lives, and we all have a part to play in this. So, yeah, thank you very much.
Thank you, Dr. Gayatri, for inspiring words. Next, Dr. Ajni Joyner, Assistant Professor in the Division of Emergency Medicine at Duke University Hospital, will be sharing with us strategies for developing a pre-hospital emergency care systems assessment tool in low-resource settings. Let us invite Dr. Joyner to speak to us. Dr. Joyner, please.
Thank you, and thank you for having me here and for allowing us to share this work that we've been doing on developing a pre-hospital emergency care tool for low-resource settings. So this project is funded by the Laerdal Foundation. So to provide some background, low and middle income countries share a disproportionate burden of death and disability due to emergency conditions, accounting for 30 million deaths per year. It's been estimated that up to half of all deaths and up to a third of disabilities from emergency conditions can be improved through strengthening and developing pre-hospital and emergency care systems. Currently, there are limited tools geared towards low-resource settings, as most of the quality assessment tools developed for pre-hospital emergency care systems are developed and validated in high-income settings. So many of you may be familiar with this emergency care system framework from the WHO. And you can see that care of the emergency patients is divided into three main areas. So you have care provided at the scene, care provided during transport, and then care provided at the facility level. And so pre-hospital emergency care encompasses both scene and transport level care. And this is where we wanted to focus because this is where we need to develop quality assessment tools so that we can assess where the gaps are and improve our care overall. So this is a mock-up of what our proposed tool is intending to look like. This is a mock-up of a scorecard. And as you can see, there are three main areas that we wanted to focus on: cardiovascular, trauma, and perinatal emergencies. And then we want to identify specific elements or quality indicators that would span across one or more of these pillars. And then the measurement performance of these tools will be indicated through simple visualization of colors. And we'll go into more detail on this later. So to provide you an overview of the larger project, we have three main aims. So the first aim is to explore potential elements of assessment for developing pre-hospital emergency care systems in Southeast Asia, and to identify perspectives in the development of such a tool through qualitative interviews with emergency medical services physicians representing South and Southeast Asian countries. Our aim, too, is to determine key elements that are specific to cardiovascular, trauma, and perinatal emergencies for these systems through a formal consensus method. And then our third aim is to pilot a developed tool in a developing pre-hospital emergency care system in Southeast Asia. And so the overview of today's talk is going to be on aim 1 and our results from this aim. So another conceptualization of this project. So we will be collecting potential elements or quality indicators from three sources: from a scoping review that's currently ongoing, through our focus group discussions with qualitative data using the CFR, or Consolidated Framework for Implementation Research framework, and then a quantitative survey, which is also ongoing. We met actually yesterday to further discuss the format of this tool. And then the final list of elements will undergo 2 rounds of an E-Delphi method, and then we'll develop a final list of elements to include in the toolkit. And then we'll have a consensus meeting in November of this year to finalize the toolkit, and then a plan to implement the toolkit in a Southeast Asian country next year. So to review the methods for this specific project, we performed a qualitative assessment of EMS medical directors from the following 6 countries in South and Southeast Asia: Vietnam, Philippines, Thailand, Malaysia, Indonesia, and Pakistan. The focus group discussion guide was developed using the CFR framework and was piloted by physicians in Southeast Asia in a low resource setting. 4 focus group discussions were conducted, and we gathered perspectives on the barriers and facilitators of such a tool that we are proposing. And then we also solicited specific elements or metrics from our participants. So I'm going to break down some of the results for you. So these are the results from CFR Domain 1, which is intervention characteristics. And these are those characteristics that are specific to implementing this intervention. And we'll go into each one of these in more detail. So our participants, I find this result very interesting. They acknowledge the importance of developing an Asia-specific tool, which I think shows us that we're on the right track as to what we're doing. And you'll see a quotation from one of our de-identified participants here, indicating that they express the need for such a tool that is specific to the Asian setting. They also noted the need to establish a tool that has similarities to other existing tools such as PATOS and PEROS, and then developing a dashboard. And then they also indicated a need for generalizability. So there's a saying in the US, and I think it may apply to other countries and other settings as well, but if you've seen one EMS system, you've seen one EMS system. And there's a significant amount of variability between systems in rural areas, urban areas. And so we need to create a tool that is going to be able to span across multiple different settings. And then our participants also noted that there was a need to trial this tool in either a specific area or with just one single disease process or pillar to start with. And they also indicated a desire to be able to focus just on one disease process at a time. Many of the settings don't have the resources to necessarily look at multiple different disease processes simultaneously, so they would like to focus their efforts on one and then maybe expand once they're able to complete one. So the results from CFIR Domain 2, these are the outer setting results. So our participants noted that one potential barrier of implementing this tool would be public sharing, or sorry, this is not a barrier, this is a request that they would like to share the data publicly, particularly with stakeholders and government-funded EMS systems. They also indicated the need to benchmark performance across other systems, whether it's within one country or across multiple countries or settings. And then one of the barriers that was noted was data sharing challenges, so particularly sharing data through the hospital setting back to EMS. The results from CFIR Domain 3, so these are the inner setting results, so those results that are specific to within the organization. So barriers for data transfer were noted. So this was particularly in respect to outcome data. So data, once it's released to the hospital, may be difficult to receive back to the EMS service. So that bilateral data transfer is not always possible in many of these settings. And then workforce shortages was also indicated as a potential barrier in many of these settings. And then finally, the need to further develop EMS systems prior to implementing such a tool as this was noted, as many of these EMS systems are very underdeveloped. And then the fourth CFIR domain, individual characteristics. So one of the perceived barriers for implementing such a tool was the lack of buy-in from EMS personnel. And as many of you know, if you work in an EMS system, the ground personnel are often very overwhelmed with tasks as it is. And so there was a concern that they may not be able to, or may not have the desire to add on additional duties such as data collection. And then finally, I find this heartening that there is a belief that this intervention will improve performance within the system. So these are the results from our request for specific elements to be proposed by the participants. And so you'll see that these are separated by our 3 pillars. So yellow represents our elements that are specific to perinatal emergencies. Pink is those specific to trauma, and blue is those specific to cardiac. And then our orange represents those that span across trauma and perinatal. Purple are those that span across trauma and cardiac. And then green are those elements that span across all 3. So in conclusion, our participants expressed the need for an Asia-specific tool for performance benchmarking, as well as the need to consider flexibility and adaptability to address constraints that are unique to low resource and austere conditions. And then among the identified barriers, data collection, transfer, and sharing were significant challenges to implementation. And then there was also a perceived lack of buy-in from EMS personnel, which indicates a need for targeted engagement of field staff when implementing such a tool. And our future work will involve refining the specific elements through surveys and consensus meetings, and then followed up by piloting the functional assessment tool. Thank you very much for your time.
Thank you, Dr. Joyner, for the meaningful sharing. We would now like to invite Major Amelia Justina Lim, currently a paramedic firefighter officer at the Singapore Civil Defence Force and commander of Jurong Island Fire Station, to share more about high-performance CPR for out-of-hospital cardiac arrest. Major Amelia, please.
Hi, very good afternoon to one and all. Thank you for having me here, and thank you for the opportunity to share about high-performance CPR. So this will be the scope of my presentation today. Okay, so firstly, what is high-performance CPR? It goes by many names. So in different parts of the world, it's practiced in many places now, actually. In Singapore, we call it high-performance CPR, and also in Seattle, and it's called MICR, minimally interrupted cardiac resuscitation in Arizona. In Korea, I think it's called multi-tiered resuscitation, or MTR. And there's also TF CPR, not Temasek Foundation, but team-focused CPR. And in some other places, it's also called a pit crew CPR because it takes after the concept of F1 pit crew. If you remember seeing the F1 races where the crew that comes in to change the tire and do all sorts of things, that is the concept of a high-performance CPR. So if we glean the key concepts from there, it's basically a team-based resuscitation that really emphasizes on high-quality CPR, minimally interrupted CPR, and of course the aim is to maximize the cardiac output and cerebral perfusion, and of course to give the best chance of survival to the cardiac arrest patients. So if I were to put the concepts into a framework, okay, so there are basically two broad areas in high-performance CPR. One is the CPR matrix itself, and of course the other one is the team dynamics. And we break down the CPR matrix component. So we have 5 components, which is the rate, the depth, the full recoil, ventilation, and compression fraction. So just bear with me while I go through the components one by one. So to optimize compression rate, so we all know that the CPR compression rate ideally should be between 100 to 120. If we compress too slow, we are basically not generating enough blood flow to the brain and the vital organs. And if we compress too fast, we basically are not allowing enough time for the heart to refill before the next compression. So this is stated in the ILCOR and as well as AHCA guidelines. The issue is, while we know this, but how do the responders know how fast you are actually compressing? And touch your heart, without any sort of guidance, I think most of us will compress too fast because of the adrenaline and because of our eagerness to help the person. Yeah. And the second metric is the depth itself. So we know this also, that we should be compressing at least 5 cm. And also there's a slightly weaker recommendation to not to compress more than 6 cm. We know all this. And also because we understand that there are patients with different physiques, so another guidelines also is to compress about 1/3 the anterior posterior diameter. And while we know this, again, the issue is how do responders know, right? How do we know whether we are really compressing between 5 to 6 cm or 1/3 the AP diameter? And of course, whether the patient is lying on a hard surface, on a soft surface, there will be a difference. So the question is, how do we optimize the resuscitating, especially in out-of-hospital cardiac arrest? And over time, the responder will be fatigued. So I think we heard from Mr. Jackson this morning that CPR is tiring, and we know all that it is physically demanding. So how do we make sure that this doesn't compromise the whole resuscitation quality? And the next one is about allowing a full recoil. So again, we know this. Why do we need to allow full recoil? Because we want to facilitate cardiac refilling for the next compression, so that make sure that we compress again we have the maximum amount of blood that we can actually push out. And the ILCOR recommendation is to really avoid leaning, to make sure that our responders don't lean on the patient's chest, because then you will not be giving the full recoil. Again, the issue is how do responders know whether they are leaning or not, whether they are actually allowing the full recoil or not. And some have suggested that over time, the fatigue will cause the responders to lean on the chest. The fourth metric is the controlled ventilation. So we deliver this using back valve mask, and we only depress 1/3 of the way, just enough to see the chest rise, and we give about 10 to 12 ventilations per minute. So why do we control the ventilation? Why we don't want to over-ventilate? Because when we over-ventilate, we may increase the pressure inside the chest cavity and impedes the blood return to the heart. And we may also induce narrowing of the blood vessels in the brain, which we don't want that because we want the blood to flow to the brain to make sure that it's perfused. And the next, the final metric is on the compression fraction itself. So compression fraction basically is the total time the patient receives good chest compression over the entire time the patient is pulseless during the resuscitation, and is calculated by a percentage. So if a patient is pulseless for a whole 10 minutes, they should be receiving chest compression, good chest compression for at least 8 minutes. The target is 80%. Now the thing is, all the interruptions to the CPR counts towards that 20%. All little interruptions counts toward that 20%. So what we have to do is we have to minimize the interruption. Unfortunately, some of the interruptions are essential to do. For example, we need to apply the diffie pads, we need to do pulse check, rhythm analysis, and we probably should not be interrupting CPR during airway insertion or IV insertion, but I think it still happens. And in the case of out-of-hospital cardiac arrest, we may need to move the patient from a crowded room to a space that has allow us to do more a better resuscitation. And the second one is about the helpful CPR provider. So why I list this as a helpful CPR provider? Why I list this as an issue? There are times when we do team resuscitation. The person doing CPR is so helpful that when someone else in the team asks for something, can someone pass me a pair of scissors? The person will stop the CPR, take the scissors, and then pass to the person, and then continue the CPR. So it's a helpful person because helping the team, but actually it may not be good in the long run because then you are interrupting the CPR. Yeah. Okay, so just to recap, the metrics of high-performance CPR, compression rate needs to be 100 to 120 compression per minute, and then depth should be between 5 to 6 cm. We have to make sure that we allow full recoil and control the ventilation, and also achieve a compression fraction of at least 80%. So the thing is, everyone knows the theory, but how do we practice it, and how do we achieve the ideal performance? So that's a big question, right? Okay. So to answer this, before that, just to summarize the issues again that I listed earlier. So basically, responders need real-time feedback. They need to know as they are doing the resuscitation, they need to know how deep they are compressing, how fast they are compressing, whether they are allowing the full recoil, and whether they are doing controlled ventilation, right? And over time, again, the responders may be fatigued. Okay, the study shows that if you do continuous CPR for more than 2 to 3 minutes, then the quality will just start to drop. Okay. And there are frequent, but some are essential interruptions to the CPR. For example, like applying diffie pads and checking rhythm and so on. And what I mentioned earlier about the helpful CPR provider, okay, who is so helpful that he stopped the CPR to take something and pass it to the other team member. Okay. And how do we optimize the resuscitation scene itself? So in the case of out-of-hospital cardiac arrest, the patients can be found in all sorts of locations, all sorts of situations. It can be on the floor, they can be on the bed, they can be sitting, they can be inside a car, they can be inside a small HDB flat toilet wedged in between the toilet bowl and the sink and many buckets of water. Yeah, so how do we actually optimize the scene so that we can do a proper resuscitation? So to answer that, I bring you guys back to the framework again. So we think the answer is at the other component, which is the team dynamics itself. So I'll break this down into 3 areas. Okay, so the role assignment, leadership and coordination in the team, and also this concept as BLS as the cornerstone of resuscitation. Okay, so in the concept of high-performance CPR, we have 2 different crews. The basic life support crew, which is typically a section of firefighters led by the emergency medical technician. And then we have the ALS crew, or the Advanced Life Support crew, which is the EMS section led by a paramedic. So this is a typical setup in Singapore. And what they do, basically, they do a very choreographed team resuscitation with a very clear individual role, and they are assigned based on who they are or what role they play in the section. And in the team, we have 2 chest compression providers who are rotated every 2 minutes. And to minimize the CPR interruptions, we coincide the switching with rhythm and pulse check. And we also have 1 assigned crew member who will keep time and also make notes, take notes and document the progress of the resuscitation. So just to illustrate the role assignment, so this is a typical setup in a 3-man BLS team. So we have a rescue 1, which is the leader of the team. He's the EMT, we call a ground commander. So he's in charge of patient assessment, he does the defibrillation, and he also does the airway and ventilation. And we have 2 chest compression men, which are the firefighters, and they will rotate every 2 minutes. If we have a section of 4 persons, then the EMT will take the ground commander, patient assessment, and defibrillation role, and the fire rescue specialist will take the basic airway and ventilation, and we still have 2 firefighters doing the chest compression. Now, this is quite a busy picture, so this is the full resuscitation team. Okay, so we have the BLS, the 4 persons just now mentioned, and plus another 3 crew members from the ALS team. So we have the paramedic, we have the conscript NSF EMT, who's helping out with the preparation of the drugs, airway, and so on. And also we have another EMT from the ambulance, and we have the EMT biker. So in SCDF, we have 5 bikers who will first respond to the scene because they can weave through the traffic quickly. So the next part on the team dynamics is really about the leadership and coordination. So what the team leader's role is to really oversee the resuscitation and also optimize the scene. So that includes things like removing distractions, for example, members of public, or emotional and can be a bit disruptive family members, understandably, but doesn't help to our work. And how to achieve the best resuscitation conditions. Maybe we need to move the furnitures around. Maybe we need to shelter the whole scene from the public eyes or from mobile phones who are taking videos, and so on. And of course, supervise the crew to make sure that they actually follow the roles that they are assigned to. And the big part of the high-performance CPR is really about coordinating the essential activities that interrupt CPR. For example, placing the feed pad, and also analyzing rhythm and checking of pulse. Mechanical CPR device, we use that if we have to continue the CPR in transport for safety purposes. And also the one little technique that we have is, if you see the picture on the right, is that whenever we have to pause the chest compression, the one doing chest compression will just hover his hands above the chest, above the actual location of the CPR, so that he will not need a lot of time to get back there and do not need to actually locate the correct point again. So the last concept is about the BLS being the cornerstone of resuscitation. So we have a lot of arsenals in resuscitation. We have the CPR, defibrillation, we have IV drugs, adrenaline, amiodarone, we have targeted temperature management, we have ECMO, and so on. But all these will not help the patient if we don't have a good basic life support at the first few minutes of the onset of the cardiac arrest. So this is the entire concept of high performance CPR, to really make sure that we have good BLS at the start, so that the rest of the treatment can really help the patient. So we drill this into the minds of our responders that the BLS crew owns CPR. They own the high performance CPR. And when the next team comes in, the EMS team comes in, the ALS, with ALS intervention, with all the sexy drugs and other interventions, they do not take over from the BLS. And what I always told the paramedics is when you come in, you don't ask them to make space for you. You find your space around them. So the BLS will continue and they do not stop for you. And to make sure that we have good quality CPR, we use real-time CPR feedback technology. So the pictures you see on the right, there's the ZOL-X defibrillator screen. So each of those bars represent one compression. So and the threshold is set there is 2 inches. So you have to make sure that you hit that threshold. And you can also see the rate, 110. So, of course, the person doing the chest compression may not be able to see the screen as he is doing the compression. So that's where the team comes in. And other than visual feedback, there's also audio feedback, like a metronome of sorts to guide the compression man how fast he should be compressing. Okay. And the one at the corner, there's a cute little CPR card. I think it was a UPAC initiative. This is about the size of a credit card that you just place on the chest, and when the responder does a CPR, there's a light that shows whether you are compressing deep enough or at the right rate range. So there are many technology out there that can help us make sure that our CPR quality is as of recommended. Okay, so a picture speaks 1,000 words, a video probably speaks 1,000,000 words. So I think next we can see the video. So I have 2 videos to show. One is a BLS of a 3-man team, and the other one is the full resuscitation with EMS. So this is the training video that we created for our responders. And just a disclaimer, this was created way before COVID. So yeah, just to say that they will not be wearing masks and all that. Okay, so maybe we can have the first video up.
Hi, yes, sir. Okay, thank you, sir. You'll be taking over. Okay, no pulse, no bleeding. No CPR.
Don't pass. Don't touch patient. Analyze.
Okay, don't touch patient. Analyzing.
Don't touch patient. Analyze. Shock advised.
Okay,
Don't touch
get the
patient.
compression.
Press flashing shock button. Don't touch patient. Press flashing shock button.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Don't touch patient.
Everybody clear?
Flashing
Yes, shock.
Shock delivered.
3,
Start CPR.
6, 7, 8, 9, back. Go compression, buddy. 4, 5, 6, 7, 8, 9, back. 1, 2, 4, 5, 6, 7, 8, 9, back. 1, 2, 3, 4, 5, 6, 7, 8, 9, back. 1, 2, 3, 4, 5, 6, 7, 8, 9, back. 1, 2, 3, 4, 5, 6, 7, 8, 9. 10 seconds to
Stop
make analysis.
CPR. Stop CPR. Don't touch patient.
Don't touch
Analyze.
patient. Analyzing. Stand by.
Don't touch patient. Analyzing. Shock advised.
Static compression.
Then clear.
Press flashing shock button.
8, 9, 10, 11,
Don't touch patient. Press flashing shock button.
20, 21, 22, 23, 24, 5.
Don't touch patient. Press flashing shock button.
Okay. Everybody clear?
Shock
Stop.
delivered. Start CPR.
4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4. Full compression. 7, 8, 9, 10.
The first video, that's just the BLS team of 3 men. And the next one is a 4-man team plus also the EMT biker and 3 men from the EMS crew. So they have a total of 8 responders at scene.
Push harder. Push harder.
If I record, we will take it from here. Taking over.
One shot given, this second cycle of CPR.
Push harder. Good compression. Stop CPR. Stop CPR. Don't touch patient. Analyzing.
No pulse.
Don't touch patient. Analyzing. Shock advised. Don't touch
Perform
patient.
compression.
Press flashing shock button.
1, 2, 3, 4, 5, 6, 7, 8.
Don't touch patient. Press flashing shock button.
4, 5, 6, 7, 8, 9, 21,
Don't touch patient. Press flashing shock button.
29, 30.
All clear? Shot.
Shock delivered.
Start CPR.
Start CPR.
1, 2, 3, 4, 5,
Push hard.
continue chest compression.
Apparently this
Good compression.
shot, 3 shots have been given, this 4 cycle of CPR is completed.
I need the IV kit.
Continue CPR.
Okay, stand clear. Stop. Stop CPR, stand clear.
Continue CPR.
No pulse. Continue 30 compression.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 21, 3, 4, 5, 6, 7, 8, 9, 30.
Okay, everyone stand clear.
I clear.
Continue.
That means I swing my back.
I'll take over LA.
IV line ready?
Push harder.
Line. Terry, I have IV up.
Okay, IV running.
Adrenaline prime.
Okay, May in, continue banking, 10
I
is
have
1.
Continue begging 10
FP here ready to go.
Okay, adrenaline,
Clamp.
8, 9, back. 1, 2, 3, 4, 6, 7, 8, 9.
Flush 10 seconds.
Flushing 10 seconds.
1 mg FP in.
9, back.
continue to prepare the next adrenaline.
Okay.
30 seconds, next analyze.
8, 9, back. 2, 3, 4, 5, 6,
Maintenance rate
8,
for IV.
9, back. 1, 2, 3, 5, 6, 7, 8, 9, 3, 4, 5, 6, 7, 8, 9, 1, 2, 5, 6, 7, 8, 9, 1, 2, 3, 4, 6.
Next compressor.
I think the concept is pretty much there. So I hope you managed to catch some of the key points that I mentioned earlier. So just to end off some new developments probably in the area. So the science is always developing. We always understand better and better how to do things. So some of the things that we are looking out for that may change the way we do things. Firstly is about recoil velocity. So it has been suggested that not only we need to achieve full recoil, we also need to recoil fast. And it has even been suggested by a small study back in 2015, just about 140 subjects, that it may be a predictor of good outcome. But however, the measurement, the technology is still quite difficult. We can't really see how fast we can recoil, although it can be an indicator of whether the responder is leaning or not. And there is an ongoing RCT in Canada on double sequential defibrillation for refractory VF. Okay, so basically it's using 2 defibrillators to deliver 2 successive shocks, and it may be a better treatment for those with refractory VF. The evidence so far has been inconclusive, so we wait and see the results of RCT, so it's quite exciting. And another area is about interaction among the CPR components itself. So so far the evidence has been showing that has been focused on individual CPR components, just the rate or just the depth. But there has been some suggestion that the components do interact with each other. So this has been identified as a research and a knowledge gap by ILCOR. So it's also something to look out for. And whether to do a continuous chest compression or 30:2 compression. So the recent paper that was published says that continuous chest compression, while it is easier to adopt, but actually is associated with lower survival. So do we go for the one that is easier to adopt, then make sure that our responders adhere to, or do we go the one that more difficult to adopt but has probably a better outcome? So maybe is it a question, is it in a training, is it in a protocol? I think the jury is still out there, but it's something that we can look out for. So yeah, that's all for my presentation. Thank you for your attention.
Thank you, Major Amelia, for the wonderful demonstration of high-performance CPR. Next, we will have Prof. Sang Do Shin from the Department of Emergency Medicine in Seoul University Hospital and the co-chairman of the Pan-Asian Resuscitation Outcome Study Clinical Research Network, who will share with us on the development and implementation of high-performance team-based CPR in Seoul, Korea. Prof. Shin, please.
Thank you very much. Good afternoon. I will talk about the same issues with Commander Rim, the development and implementation of high-performance team-based CPR in Korea. I have told you in the morning session, the OHCA 10 steps recommended several programs for community and EMS resuscitation. So I would like to talk about the high-performance CPR and the rapid dispatch and professional measuring. I like this picture, so I have talked to you in the morning. We have implemented new program. We should get more data. So for the first 5 years, we have 2 resources, and then following the 5 years, another 2 data source, and then another 5 years, we have 2 another resources for measuring about our new implementation of the program. The 2-tier response registry and the professional recording registry. This picture I have told you in the morning, the 5 programs started in the phase 3 phase 2. And among these programs, the high performance CPR and rapid dispatch and the professional measuring is specific for the EMS resuscitation program. So in Seoul, we have found that the survival curve was turned down in 2014 after peak in 2013. So we have looked at the data seriously, and then we decide, and then we conclude we need a new vulnerable treatment program in EMS. So we carefully look at our data, and we recruit the idea, and then we have implemented a new program for. The first is high-performance CPR, which was described and presented by the Commander Rim. And then second is the high-quality dispatcher CPR. Actually, we have implemented dispatcher CPR in 2012, and then we look at the data. We need more exact and the more higher level of quality assurance program required for maintaining the dispatcher CPR. And third is rapid dispatch. I told you before, our response time is very difficult to get the achievement of the time. Like Singapore, Seoul is a very high-rise building and traffic jam and much more people living there. So response time is not following the increase of the call volume, not following the increase of the demand of the service. So rapid dispatch is a very important component for making change of our survival outcome. The final is we should evaluate and measure how is the CPR happening in the EMS by the EMS providers. So we should negotiate with the paramedics and EMTs in fire department to measure the professional job of there. So how can we develop the high quality assurance program? High quality assurance, high quality dispatcher CPR. So we have a monthly based education and training program developed, and then the supervisor of each team of the dispatch center look at all data and review the audio tape, and then take the feedback back to the all team members every month, because from the medical directors can give a good comment, but the supervisor by him or herself can make a review and get feedback. Is much frankly speaking together, and then it takes a more good benefits. So, and finally we get feedback to the all teams by the medical directors of the dispatcher center. This can make some high quality medical review and dispatcher CPR program. Second is a tiered response system. I told you before, we have a very difficult to get the fast response. So we decide to invite the fire engine or available ambulance to provide services at the same time for the one person. So Seoul is a metropolitan, 600 square kilometers. It's a big city. So we can design to select two vehicles, not only the ambulance, but also we can select the available fire engine. So dispatch center provide us a telephone CPR after receiving call, and then send the first available fire engine or ambulance, and then followed by another ambulance. So we expect this can make some better, faster response. Then third, it is very different situation. Commander Rim told you we have only 3 persons CPR team in the past. Now we have 6 or 7 or sometimes 8. So it is very difficult to provide. How can we provide high performance CPR on the basis of a team member number? So we designed 3 person, 4 person, 5 person, 6 person. Too difficult. The paramedic EMTs very confused, and the fire engine and truck, they are almost firefighters, and then the others ambulance service providers. They are separate, working at another division. So it is not easy to make some good team, but it is very difficult job. But we have developed a more simplified method for 3-person or more than 3-person program. And finally, is that this is very device-based on the program. We can get the data from the real-time feedback devices. It is very costly, so we decided to buy this kind of the high-cost device to measure the CPR record. We can get the depth, rate, CPR fraction, and then pause. We can get the data, but we can measure and calculate the review data, and then we can get feedback to the fire department monthly basis. A medical director can review and get back feedback. But at the field, the EMTs and paramedics can know whether the CPR by themselves is going on well or not. So they can do well, but we reviewed and data can back feedback by monthly. So we expect this data is from Seoul. We are expecting the turn down the curve is turn up to the much better outcomes in 2015 and 2017. We are expecting 2%. So we developed a more registry for the multi-tiered response registry and then professional CPR recording registry. The first one is based on there are 2 vehicles. So last vehicle should record the EMS run sheet and the CPR registry, but first response vehicle should record for some factors, for example, the arrival time and what's happening there. So those data can be merged as a one episode, and then we can analyze the data to get feedback. And also professional recording is on the basis of a patient record, CPR record, and then device record. We can merge that, and then we can analyze the result. From these 4 bundle of new program, each program has each key performance index. So for example, high quality dispatcher CPR, we can measure the detection time interval, which is the time from collapse to the first compression, which is the bystander, which is the detection time interval. And then rapid response is the dual response system has the key performance index as for the response time interval. And then high performance CPR program. So we have more team members in the field. We can stay longer time than before, so we can give a more higher level of services like intubation and then IV fluid and then sometimes a drug medication, and then sometimes we can use more easy way to compression by the mechanical compression devices. So this kind of new devices and services should be measured on the basis of the high performance team CPR program. And then finally, professional recording, record the many depths and rate, but we can measure only the how many cases can be measured by the feedback CPR devices. So the 2% is a nickname of this project. So we have a goal to assess the effect of the new bundle of implementation for the UTI's 4 group of services. And then we analyze the data before and after for 2 years and 2 years. And then I told you for interventions for the 2 years. It was published in Resuscitation. And then we analyze the before and after. Then finally, you can find the dispatcher's CPR was 32% to 43%. Multi-tier response was 0% to 57%. And then feedback CPR measurement was 25% to 78%. And also we can find more the other factors. For example, EMS resuscitation, advanced airway management was just increased 7.8% to 61%. And then fluid resuscitation was 2.4%. You know, the 3 persons provide the CPR in the field. At the time, we cannot provide any fluid. But we have 6 members, 7 members. We can provide more fluid. So 2.4 to 48%. And then mechanical CPR was very low in the first half of the year, but when we have 20% of cases can be managed by the mechanical CPR device. Usually the protocol encourages that the patient should be applied when the patient is starting to transport rather than in the field. So we are targeting for the mechanical CPR for the only way to the hospital. So from this data, we can get more good outcomes. So we have expected 2% of survival. It was not 2%. 9.6% increase, 10%, 10.9%. So we have get some good outcomes, and then good CPS also improved. The odds ratio after adjustment was 1.45 times. My summary. So high performance CPR and the rapid response and the feedback program and the continuing of this high quality dispatcher CPR can make sense and efficient and beneficial. And but it was tried in Seoul in these years, and then it was expanded to the whole country. Now in whole country in Korea, we have those programs was implementation in 2018, 19, 2020. So national implementation should be measured and evaluated. What's happening there for the rest of 3 years? But as you know, the COVID-19 was pandemic in Korea. So we should carefully look at the data. What's the problem? What's the long? What's the difficult? So we should make a change. Thank you very much.
Thank you, Prof. Shin, for the insightful sharing. Now, we'll be having a panel discussion with our speakers, moderated by Dr. Andrew Ho, Emergency Physician at the Department of Emergency Medicine in Singapore General Hospital and Assistant Professor of Duke NUS Medical School. May we now invite our speakers to join us on stage.
Hello everyone. I think I speak for everyone here when I say that was a really insightful series of presentations by our guest speakers. So my name is Andrew. I'm pleased to be moderating this panel discussion. We'll be inviting any questions, from both our in-person and also Zoom participants. We already have a first question from Dr. Rao.
I just wanted to ask about the effective CPR. You had told that only 3 people are there. At the head end, he is the commander, he is the person who is putting the IV cannulation, giving the medication, and he will be giving a defibrillation also. So one individual doing all the 3, will it be effective?
Thank you for the question, Dr. Rahul. I think the question is why the EMT is taking so many roles as compared to distributing the roles to the other team members. So this is actually because the roles and the task is assigned based on the skill set of the responders. So the ground commander is the emergency medical technician, who is the one who is trained to do every cannulation and to do patient assessment. And the other 2 team members are actually firefighters, so they are only trained up to a BCLS skill set. So we do this because we want the training to be easy for the crew, so that they know that their roles based on what their vocation is. So that's how the team is designed basically.
Another fast question about how does the double defibrillation will help to, you said defibrillation, the last part of your presentation was about defibrillation, giving shock 2 times. I understood like that.
I think you're referring to the
dual sequence.
Yeah. So I think that one is okay. I honestly I don't know much about it. I read the paper, but I don't really know much about it. So it's basically using 2 defibrillators to deliver 2 successive shocks only for refractory VF, for persistent VF. So I think it's being practiced in some places, but we are still waiting for a very conclusive evidence whether it really supports the outcome. Thank you for the question.
Okay, don't mind me asking, is there a way to allow community first responder to help with the EMS during cardiac arrest during high performance?
Yeah, thanks for the question. I think that's a really great question. I think in the second video, we did not feature the bystander there, but I think the bystander really plays a crucial point because you are the one who has the first contact with the patient, and that gives us that you have a valuable information on how the patient was when you found the patient and what you have done and all that. So although it was not featured in the video, but it is part of our practice that when the first responder comes in, you will tell the community first responder, don't go anywhere, stay here, I need some information from you later. Yeah, so the information is really important, and of course you can also help out when the team comes in. You can help out in what I mentioned just now about optimizing the resuscitation situation, helping out, maybe managing family members who are concerned and all that. Yeah, so I think it's a very important role for the CFRs to play. Thank you.
Hi, good afternoon. Hi, I'm Dr. Fong here from NUS, Institute of Data Science. So I'm a computer scientist by training, so please forgive me if my question is a bit naive. So from a technology point of view, since being a technician, for various technology, including data analytics, artificial intelligence, or even robotics, I would like to hear from the panel, where do you see some of this technology may come in to solve some of your pain points? For example, a naive observation seems the CPR is a very repetitive, tiring, and yet standard procedure. Do you see, some robotics may come in to provide the naive thinking, right? Some alternative to replace some of the manpower. Just want to hear from all of you various ideas. Thanks.
Any of you can go first. That's a fantastic question. How can we harness technology in our EMS to maybe take over some of the mundane work that sometimes in other industry we see are better performed using machines. So let's hear from our expert speakers. Like what are our experience implementing some of these devices or potential areas for devices to be developed.
I can speak to our experience in Durham, North Carolina. So we use mechanical CPR devices on all patient encounters that are able to fit within the device. And I think a lot of the data is still up in the air as to whether or not these devices make a difference. But the reason why we prefer to use them is more for our provider safety. So it's very dangerous to perform CPR in the back of an ambulance, and it's not quality CPR that's being performed. And so that is the primary utility of using those mechanical CPR devices.
For example, I think we can think on other cases like cancer treatment. For example, the colon cancer, stage 4, we are starting to treat with chemotherapy or sometimes local radiotherapy, and then we can, if we have a chance, we can operate, and The kind of new devices in EMS is the same things. We are doing manual CPR sometimes, and then we can give another treatment device like a mechanical CPR or a kind of injection or the drug. It's a new treatment. So we should carefully look at the patient, what kinds of care should be given. So it is not equally replaced, not equally replaced. So human CPR cannot be equally replaced to the mechanical CPR. But I just my theory. So from the manufacturing company or the technology, we can get good inspiration for getting chance for change of our practice. But we should carefully look at the patient, and then our new device, new care therapy should be aligned for making the best outcomes. It's my idea. So my story is in Korea, mechanical CPR is good, very good, but more people can be confused when they applying the machine in the field. In particular, 3-person CPR, it's very chaos. So theoretically we can think the 3-person has a very lack of hands, so mechanical device will be very helpful, but we are doing the application of the mechanical device. Some of the people should stop hands compression, hands, and then we can make some time. We use some time, and then it result in the kind of the stopping CPR. So how do we apply the machine when, for our circumstance, our environment? It is very important for our EMS providers and the EMS directors.
Yeah, I totally agree on that. And from the emergency department's perspective, so your idea sounds, it's great. The challenge in that is that the patient's being transported from the environment into the emergency department. So even with our mechanical CPR, we do face challenges like, for example, we have to swap the mechanical device, swap the EMS mechanical device to the hospital device, and that requires a few people to manipulate the patient to get there. Then there's issues with the battery charge time and the bulkiness of the machine. So these are some challenges with technology, which if can be ironed out, then it might be helpful. But at the start, for now, it's still a big challenge.
Okay, so this moderator has a question for the panel. In our region, we have a range of EMS systems. So some are more developed and advanced with a longer history, but some are newly coming up, newly developed. So what do the panelists think is the biggest opportunity, where they can, where these systems, newly developed EMS systems, can achieve improvements in patient outcomes? The biggest opportunities to you?
So I will first and then follow finally the developing community plan is perfect, our discussion. Please show me the presentation file for discussion. Yep. I'd like to talk about the NOT CPR project in Seoul, which is a new idea and concept, the new CPR program designing and implementation. Next. So could you think about the pandemic? It's a crazy, like a second world war, or third war, I'm not sure. The patient more witnessed in home, and the bystanders, more bystanders at home, and less trained. The opportunities are less and less. Dispatchers, more call volume, less qualified. And the first responders, more overloaded, but less trained. Paramedics, burnout, less qualified. And the physician, burnout at ER. So less interest in EMS. Next slide. So we in Korea, we have idea from the basic services and intermediate service, more comprehensive services. So we put the more data, more data, more data. We put the more resource and resource and resource. We invite more technology, actually more money. But we started in 2018, the ALS, Advanced Life Support, were implemented. So protocol developed, and then providers were educated. And 19, we have pilot trial. We had a trial. And then 2020 is a pandemic year. We expanded, unfortunately. And then 21, first evaluated, not good. And then 22, now it was generalized and registration will be done. So we have 5 protocols. Epinephrine for CPR, pain control for major trauma, EpiPen, anaphylaxis, cord clamping and cutting for delivery, and ECG interpretation, and then hotline activation. This is a usual, very comprehensive EMS program for the advanced care. Next. But the COVID broken our idea, and then we have a very difficult to set up on the basis of our idea. So now we should make a RENOT. It means the Korean Network for Outstanding Team CPR, which is a kind of new concept, network CPR. In the past, only one patient received by the EMTs when the ambulance service arrived. Now, dispatcher CPR, we can provide the CPR by neighborhood and the dispatchers. And then now, we can get more good opportunity, like everybody can be connected with online. So we can give a CPR by all teams of the community, from dispatcher center and ambulance crew and home bystander and virtual physician together. So one patient can receive all kinds of services by the new network team CPR. So this is a new idea, but what's happening? We can provide the new CPR by only dispatcher, by only bystander, by only EMS provider. No. Now we can change our idea to provide together from hospital, dispatch center, ambulance services at home. It's my idea and recommendation. Next slide. So those 5 providers should be linked together. The training, network CPR training, and dispatcher CPR, and more artificial intelligence-based training, dispatcher. And third, audiovisual ALS together, seen by the together all teams. Next. So we have a development of the 3 action plan. One is a network CPR training, not service, and the AI dispatch, and then AV ALS program. So this kind of 3 programs can change our service after COVID pandemic situation. Thank you.
I think I'm supposed to go next. So I think the question is about the biggest opportunity in developing EMS. I think the one that we should not forget, or even the one that we should probably start as soon as possible, is really to engage the community and to really establish a system where the community is really part of the EMS system. Because it's very simple. No matter how strong the EMS system is, it still takes time for the EMS to get to the patient side, and the first responders are always the community. So I think that's one of it, that when we're developing a new EMS system, I think from the very beginning involve and include the community. I think that's very important. Thank you.
I would say what is happening here today is key. So collaboration between different countries and communities, and taking some of the lessons learned in one setting and translating it to a different setting. I think there's a lot of room for opportunity there to not reinvent the wheel and to work with what has been successful somewhere else.
Okay, so I think what I would think is important and an opportunity, especially in this post-COVID period, would be the engagement of stakeholders and not giving up and trying different methods. So engagement of stakeholders are twofold. One would be the community, the public, and the second would be those higher up, which includes the government agencies. And the EMS system kind of is sandwiched in between. But if we can't actually engage the government stakeholders, the ones higher up, then another way to go about doing it is to engage them via the public, because sometimes you may have very strong public voices in the form of NGOs or advocacy groups that may help to actually promote this, the EMS agenda. So there may be more than one way to go about doing the same thing. But it's important to involve the different stakeholders so that you can actually explore the different ways of achieving your same goal.
I think that is all the time we have. So we thank all the panelists for their time and insights.
Thank you very much.
Thank you.
Thank you very much.
Thank you, speakers, for your enlightening panel discussion. You may now return to your seats. Ladies and gentlemen, we have now come to the end of the afternoon session. I believe all of us have gained new insights on pre-hospital emergency care from all our speakers. We would like to thank our virtual guests for joining us today.